The floor is yours.
I'll speak to you tonight about the acute adrenal insufficiency. So let's start with this clinical case. This is 23 years old male who is a known case of congenital adrenal hyperplasia, the commonest type, which is the 21 hydroxylase deficiency. He was kept on prednisolone 5 mg once a day and fludrocortisone 0.1 mg once a day. 1 week prior to his presentation, he was diagnosed with TB arthritis and he was started on anti-TB medication. He was brought by his father comatose with a blood pressure of 40 with undetectable diastolic blood pressure and a blood glucose level of 1.5 millimole per liter. The patient was intubated electively and resuscitated with IV fluid and normal saline and D50. No doubt about the diagnosis of this case that he's having adrenal crisis. By the end of my presentation, I hope everybody will know the precipitating factor for the adrenal crisis for this patient and will have an idea about the other precipitating factor and the management of the adrenal crisis. So glucocorticoid replacement therapy, which is available since 1950, has prolonged the survival of patients with adrenal insufficiency. But adrenal crisis still develop in many affected patients, and over last decade, the frequency of the adrenal crisis appear to be increasing despite the availability of effective preventive strategies. Patients with adrenal crisis present systematically annual with non-specific sign and symptom, leading to misdiagnosis and delayed treatment. To make the life more complicated, sometimes the adrenal crisis will be the first presentation of the adrenal insufficiency. So what is the definition of adrenal crisis? There is more than one definition, depend from whom you are reading, but I'll focus in the most widely acceptable definition, which is the last one. It is more clear in this slide. So it is acute deterioration in the health status associated with absolute hypotension, defined as the systolic blood pressure less than 100 milligram mercury, or relative hypotension, which is defined as systolic blood pressure more than 20 lower than the usual. So normal blood pressure in a patient who is already non-hypertensive will not rule out adrenal insufficiency. And the features will resolve within 1 to 2 hours after parenteral glucocorticoid administration. So adrenal crisis should be included in the differential diagnosis of any patient who presents with hypotension that does not respond to the IV fluid administration or vasopressor. And again, the opposite. In any patient with hypotension, which was attributed to an adrenal crisis, if he didn't respond to the usual dose of hydrocortisone, please think about other differential diagnosis. This table summarizes for you the symptom, sign, and biochemical characteristic of adrenal crisis. So the commonest symptom is gastrointestinal, anorexia, nausea, and vomiting. Patient usually will have generalized pain, smelly abdomen, but he can present with limb or back pain. The patient will be really having severe fatigue, severe weakness, Busher dizziness, syncope, and confusion. Sign which you will look in the patient examination. Hypotension is universal in the patient with adrenal crisis. Abdominal tenderness or GERD, hyperpigmentation only in primary adrenal insufficiency. Patient might present with fever, impaired consciousness. Patient can present with delirium, obtundation, or even coma, like the patient I present. Biochemical abnormality, hyponatremia is almost universal for all patients with adrenal crisis. Hyperkalemia only in patients with adrenal insufficiency. Hypoglycemia is more common in the children. It's rarely to happen in adults with adrenal insufficiency. However, it does happen, like my patient. Hypercalcemia, neutropenia, eosinophilia, lymphocytosis, and mild normocytic anemia. I want you to know about the other term, which is the incipient adrenal crisis. It is just precursor of adrenal crisis. So it is acute illness in any patient with adrenal insufficiency without hemodynamic compromise. The treatment more or less the same, like adrenal crisis, with IV hydrocortisone and IV fluid. So you will prevent the development of adrenal crisis. What is the pathophysiology of adrenal crisis? It is not yet fully understood, but in a simple term, it is just mismatch between the need and the availability of the cortisol. Patient with acute stress will require huge amount of cortisol, more than usual. So what happens, there is this amount of cortisol which the body needs to deal with this stress will be less than what is supposed to be. So the patient will present with adrenal crisis. As you know, you need cortisol. Cortisol works in all the major organs in your body. So if you don't have cortisol, you will lose the synergistic effect with catecholamine on the blood vessels, so the patient will present with hypotension. Other reason for hypotension, lack of cortisol will decrease the conversion of norepinephrine to epinephrine. And everybody knows that the epinephrine is more potent than norepinephrine to maintain the blood pressure. So this is another cause for hypotension. Lack of cortisol will affect the immune system. So there will be activation of cellular inflammatory pathway, and there will be increase in inflammatory cytokines. So TNF, alpha, interleukin-1, interleukin-6, all will be increased. So this will lead to the sickness syndrome, fever, and fatigue. Lack of cortisol will decrease the gluconeogenesis in the liver, which contribute to hypoglycemia. It will lead to reduction in the production of free fatty acid and reduction in the amino acid. Hyponatremia, almost universal in all patients with adrenal insufficiency. If the patient is having primary adrenal insufficiency, lack of mineralocorticoid will make the patient situation even worse. Hypotension, hypoglycemia, increased inflammatory cytokines, and the lack of cortisol itself will affect the brain function. So that's why the patient will present with delirium, obtundation, and even coma. The incidence of adrenal crisis is almost 6 to 8% of all patients with adrenal insufficiency per year. And it is slightly more frequent in a patient with a primary adrenal insufficiency. As I mentioned, over the last two decades, the incidence of adrenal insufficiency is increasing. The exact reason is not known, but it might be attributed to the current use of lower dose and short duration and short-acting glucocorticoid regimen. Like most of our patients now, they are in the hydrocortisone, which are dose ranging from 15 to 20 milligram a day. In the old days, most of the patients were in the long-acting glucocorticoid like prednisolone, and in higher dose, which is equivalent to 25 to 30 milligram prednisolone per day. So low baseline cortisol level may contribute to increase the incidence of adrenal crisis. The mortality is 6% of crisis events, so it is easy to remember. Incidence of adrenal crisis is 6 to 8% of all adrenal insufficiency, and the mortality is 6% of all the crises, which is more or less 0.5 per 100 patient per year, which is almost 1 patient per 200. Keep in your mind that the fatal adrenal crisis have occurred in patients without the preceding diagnosis of adrenal insufficiency, although the symptom might be present for a while, but unfortunately it was overlooked. The risk factors for adrenal crisis are older age, history of prior adrenal crisis, the presence of autoimmune polyglandular syndrome, type 1 diabetes mellitus, non-endocrine condition like bronchial asthma, cardiac disease, respiratory disease, and there is unknown factors which might potentiate the risk of adrenal crisis, because it's very noticeable that some patients have numerous episodes, whereas other patients have a few, if any, episodes. The precipitating factors for adrenal insufficiency, the commonest one is infection. Other are serious injury, major surgery, initiation of thyroxine therapy in a patient with undiagnosed hypoadrenalism, initiation of cytochrome P450-3A4 inducer without doubling the dose of baseline prednisolone, like what happened to the patient I present. Exercise and emotional upset have been reported to cause adrenal crisis in up to 10%. Although in these two situations, you don't need high level of cortisol. And again, it was reported in association with the release of acute phase cytokines after certain just minor medical procedures, such as vaccination or zoledronic acid infusion. Immunotherapy or chemotherapy may precipitate the adrenal crisis, and especially immune checkpoint inhibitor. Now, in the oncology guideline, any patient who is already on immune checkpoint inhibitor present to emergency room with acute illness, consider him to have acute adrenal insufficiency until proven otherwise. Other precipitating factors is sudden discontinuation of steroid, either by the patient or sometimes, unfortunately, by the physician. Rarely you will not find any specific precipitation factor for the adrenal crisis. This is 3 studies summarized for you the precipitating factors and the percentage. If you notice clearly, the infection is the commonest. And from the infection, the gastrointestinal illness is the common precipitating factor for the adrenal crisis. Management of adrenal crisis. For any patient acutely ill, you need to follow the ABC, the airway, breathing, and circulation. Patient need to be started on IV fluid, IV steroid, and you need to manage the underlying cause. What is the dose of hydrocortisone? The recommended, what is the dose of the steroid? The recommended one is the hydrocortisone. 100 milligram IV bolus. You can use IM if you didn't have IV access, followed by 200 milligram of hydrocortisone per 24 hours, either as a continuous infusion or in a dose of 50 milligram IV or IM injection every 6 hours. IV fluids. You need to be very generous with IV fluid, of course, based on the patient condition and background. Patient need to receive at least 1 liter of IV fluid boluses over the first 1 to 2 hours. Maintenance IV fluid should follow based on the patient clinical response. The recommended IV fluid is normal saline. However, if the patient is running low blood sugar, it's better to have to add D5 to normal saline. Remember that diagnostic investigation should never delay the treatment of adrenal crisis. You can draw sample for the cortisol and ECTH level, but please don't wait for the result. If you suspect adrenal crisis, give the 100 milligram hydrocortisone. The confirmation of the diagnosis can be done safely once the patient has clinically recovered. Having said that, and you know the recommended dose of hydrocortisone, please individualize the care. Like every and each patient is different from the other. So keep on monitoring the patient, the response, the dose of hydrocortisone. Your patient might require higher hydrocortisone dose than recommended, especially if he's taking enzyme inducer. The common C3 medication, the common C3 enzyme inducer, which can be used by your patient is phenytoin, Tegretol, and rifampicin. Keep in your mind if the patient is not responding within from the first 2 hours to the IV hydrocortisone, please think about other cause for the hypotension. And the best thing is really to try to prevent the adrenal crisis by educating the patient about the 6 days rules. So we have the oral stress dosing of glucocorticoid. You will educate the patient to doubling or even tripling the replacement dose of cortisol depending on the intensity of the stress until the illness resorts, usually within 3 to 5 days. Please keep on educating your patient and keep on reminding them. Like for me, in every and each clinic visit, I remind the patient about the importance of doubling or tripling the steroid dose. And if the patient is having vomiting, diarrhea, or severe illness or trauma, patient should receive parenteral hydrocortisone, 100 milligram, either by the patient himself or one of the family members. And even if the patient managed to receive IV hydrocortisone, encourage him to present to the ER as early as possible. Patient and their family members should be taught how to perform intramuscular injection of hydrocortisone and should be provided with vials, needles, and syringe. Too many patients and family found the IM injection is really difficult and not acceptable route of administration. So subcutaneous administration of hydrocortisone is an alternative. It is still off-label method of treating acute adrenal crisis, but pharmacokinetic data indicate that subcutaneous and intramuscular injection in non-obese patients with adrenal insufficiency without shock have similar effect. Other route of administration is rectal hydrocortisone suppository. Like you can give the patient 100 milligram of hydrocortisone per rectal. It is very effective way of treating adrenal crisis, especially in the children. And plasma level of 1 to 2 hours after 100 milligram of rectal hydrocortisone almost reach 1,000 nanomole per liter, which is more or less like the IV hydrocortisone. Every patient should wear either medical alert bracelet or he need to carry the steroid card all the time. In spite of all the effort directed to encouraging the patient to manage their glucocorticoid treatment in order to prevent adrenal crisis, actually only some patients initiate dose escalation effectively. And the outcomes from intensive patient education program are disappointing. That's why still now we are seeing the patient with adrenal crisis. And this problem is not only in our population, it is worldwide. Any patient with adrenal insufficiency who is going for the surgery need to receive higher dose, either doubling or tripling the oral dose for simple procedure like tooth extraction, or giving or giving them the maximum dose of hydrocortisone.
1 minute.
For major procedure like cardiac surgery, and remember, ladies during labor or normal vaginal delivery, they need stress dose as well.
Dr. Salha, you have 1 minute more. Okay.
Sure, I'm almost finishing. So don't forget, I call this type of patient are the forgetting patient. They are the patient who are receiving immunosuppressive steroid. These patients are never in our endocrine clinic, and really their knowledge and education regarding the adrenal sufficiency is far more less than our endocrine patient. A future approach, just to make the life more easier for our adrenal sufficiency patient, a preloaded hydrocortisone syringe similar to the epinephrine auto-injector has been recommended, but is not yet available. And there is another route like intranasal or inhaled spray or powder for hydrocortisone. Just back to our patient. So our patient, he was having adrenal insufficiency, congenital adrenal hyperplasia. Patient was started on rifampicin, which is strong enzyme inducer, without increasing the dose of prednisolone. That's why the patient present with acute adrenal insufficiency. So he received 100 milligram by the ER doctor, but he continued to be hypotensive. So endocrine team was contacted. So he received extra dose, 200 milligram, because with enzyme inducer, you need higher dose. So he clinically improved. He was planned to receive 100 milligram every 6 hours, but after the first 100 milligram dose, he became hypotensive again. So the dose was increased to 150 milligram every 6 hours. Patient improved, and he was extubated in less than 24 hours. And he was discharged home in good condition on prednisolone 15 milligram once a day and fludrocortisone 0.2 milligram once a day. All of these could be prevented if the ID doctor double or triple his dose of prednisolone. So in conclusions, adrenal crisis is a life-threatening endocrine emergency that requires early recognition and treatment. When suspected clinically, adrenal crisis must be treated with prompt hydrocortisone treatment and IV fluid. Please individualize the patient management, and all patients should be educated regarding sick days rules and encouraged to carry a medical alert bracelet or steroid emergency cup. Thank you very much. I took 3 minutes extra, sorry.
Thank you very much, Dr. Salha, for your elegant and extensive review of acute adrenal insufficiency. It is really very important topic. We have some question actually, but we'll leave it to the end with the whole panel. So we'll go now to the second speaker. It's really a great pleasure to introduce our senior consultant, Dr. Nasser Al-Gahtani, who will talk about the thyroid storm. So Dr. Dr. Nasser, the floor is yours now.
Thank you so much. Okay. Assalamu alaikum. Our topic today is we'll talk about thyroid storm. The best thing is to start with a case. Our case is 57 years old lady, which is she's known case of grave disease. For about 2 months, she was prescribed carbimazole and atenolol, but the patient stopped her medication about a week ago. She presented with history of nausea, vomiting, and palpitations. She made her way to the emergency, found to be febrile, 39, tachycardia with regular pulse. She got orbitopathy, and thyroid examination shows diffuse goiter with bruit. She is in heart failure with rails at bases, and her The neurological examination was within normal. The blood test shows that her T4 and T3 was high with suppressed TSH, and her bilirubin is 1.5. The ECG shows sinus tachycardia, and chest X-ray shows pulmonary edema. So what is how common is this condition, the thyroid storm? So the incidence in the general population is about 0.5 per 1,000. And all hospitalized patients, it's range between 4.8 to 5.6 per 1,000 per year. And all patients coming with thyrotoxicosis hospitalized is ranging between 14 to 18 with a mortality of 1.3 to 3.6. So if you look into the first graph, in 1934, the mortality is almost 100%. If you look into the 2019, here is drop from 100% to 4%. And why is that? Because iodine was introduced in 1920, the thiamides in 1940, the steroid in 1950, and the beta blockers in 1960. So with these medications, mortality decreased dramatically. So what is the difference between thyroid toxicosis, we call it uncomplicated thyroid toxicosis, and thyroid storm? If you divide the clinical features in thermoregulatory, your patient that you are accustomed to with thyroid toxicosis, they have heat intolerance and diaphoresis. But if the patient is having thyroid storm, this will be hyperpyrexia and large insensible fluid loss. The nervous system is hyperkinesia, and nervousness becomes confusion, seizure, and coma. Cardiovascular, the tachycardia becomes accelerated tachycardia with dysarrhythmia and heart failure, and so on. And the gastrointestinal, which is the hyperdefecation, becomes nausea, vomiting, and diarrhea. And death is very rare in uncomplicated thyrotoxicosis, but frequent in thyroid storm. So in summary, the thyroid storm is a wild form of uncomplicated thyrotoxicosis. Before 1993, there is no uniform criteria for diagnosis. Most cases had common features. There is wide spectrum of dysfunction with high mortality, and most diagnoses, I think, that translate in high mortality. So Persh and Wartofsky create this, what we call it, the thyroid storm point scale, and they give numerical scaling. And this, based on this scale, if the patient is having severe thyrotoxicosis and he scored more than 45, this is thyrotoxicosis. Between 25 to 44, this is bending. And if it is less than 25, this is unlikely. So this is 1993. Then the Japanese came with Japanese Thyroid Association. They came with their diagnostic criteria. It's what's the difference between them? It's empirically derived diagnostic criteria, have some general categories as Persh, Wartofsky, point scale. It's a modified based new cases, but there is no numerical scale. And this came on 2012. And this is their criteria. They call it TS1, TS1, and TS2, and TS2. TS1 means confirmed, TS2 means possible. So this is the first combination. The second slide will make it easier for us. So thyroid storm means thyrotoxicosis and CNS disturbance, and one of the four, the fever, tachycardia, heart failure, and GI or hepatic abnormalities. Combination 2 means thyrotoxicosis, that there is no CNS, but you have to have 3 out of 4. If possible thyroid storm, combination 1, thyrotoxicosis, no CNS, and 2. And combination 2 means that you don't have T4 or T3, but meeting other criteria of thyroid storm. So back to our patient, he scored 60, which means thyroid storm. And if you plot him on the Japanese criteria, he is on the confirmed thyroid storm. So how do we treat this patient. The treatment is directed at every therapeutical accessible target, i.e. inhibit the thyroid hormone synthesis and release, prevent peripheral effects of thyroid hormone, removal of thyroid hormone, provide systemic support, and identify and treat the precipitating cause. So if you look into the 2016 ATA hyperthyroid guidelines, they said methimazole in all patients except the pregnancy and thyroid storm. And why is that? Because if you give BTU in high doses, it drops your T3 more rapidly than methimazole or carbimazole. And this study shows that in the first day by BTU, you drop your T3 by almost like 50%, while the methimazole or carbimazole by 13%. What's new? Parenteral antithyroid drugs is available, but it's not approved preparation. But as this case, who was 42 years old with thyrotoxicosis and severe hematemesis, they couldn't give him oral, so they give him IV methimazole, and you could see the trend of his thyroid function is coming down. If IV cannot be given or is not available, then PTU suppository is also available, and these determine therapeutic drug levels. Second is to give an organic iodine that will inhibit the release of thyroid hormone. What is the dose? Is 5 drops if you are giving SSKI, and should be mixed with water or juice. Traditionally and textbook, they said wait until 1 hour after first dose of ATDs, but the Japanese, they are using it simultaneously with the antithyroid drugs, and there is no problem with that at all. Peripheral effects of thyroid hormone. So because of that, you want to inhibit T4 to T3 conversions. PT will do that, propranolol, corticosteroid, or the old cholecystographic agent. And you want to block the effect of thyroid hormone on the end target organ by beta blockers and corticosteroid. Propranolol, most frequently cited, block T3 to T4 conversions. The dose is 60 to 80. The problem with the propranolol is half-life is long, 3 to 4 hours. It may cause cardiovascular collapse and is contraindicated with severe asthma. Japanese, they don't use propranolol, they use esmolol. I think this is the standard of treatment of beta blockers for their thyroid stone patients. So it's beta-1 cardioselective, very short half-life. This is the doses. And because this patient managed in ICU, you just consider invasive monitoring for patients who got congestive heart failure while they are treated with beta blockers. Physical removal of thyroid hormone. If patient is not responding to your measures, then you might consider plasma exchange. And in the literature, there are 125 cases reported in the literatures where the plasma oxygen or charcoal perfusion was done, and there is a clinical improvement with this modality of treatment. When do you use it? You do this when you're back against the wall, that your patient is not responding to you, or the patient developed a problem regarding the adverse event for antithyroid medication. And this is one of the cases that the patient have side effects, so methimazole with granulocytosis. So you could see that the T3 and T4 after stopping the carbimazole went to the roof. He was started on hydrocortisone beta blockers, but no much improvement. They start in plasmapheresis, and there is a nice drop of his thyroid hormone, and that's make him candidate for thyroidectomy. The other thing is you have to use this binding resin because it's interfere with the enterohepatic circulations, and the one that we are being used is cholestyramine 4 milligram 4 times a day. And there is crossover study shows much improvement if you combine both rather than using just only methimazole. Literature shows there is 10 cases of urgent thyroidectomy because the patient is not improving, but the mortality is around 20%. But sometimes you have to consider this. Systemic support, patients are managed in ICU for fever, acetaminophen, for not aspirin, because of displace the thyroid from binding protein, make it accessible as free thyroid hormone, the hydration, the nutritioner, and then the telemetry and the invasive monitoring. So the summary of drugs and doses thyroid storm as plotted here, the BTU is 500 to 1000, methimazole is 80 to 120, the osmolol or propranolol if you are using it, the iodine as a form of SSKI, 5 drops, hydrocortisone, and or dexamethasone 2 milligram IV or oral. What's the prognosis? What's the cause of death? Multi-organ failure and congestive heart failure constitute about 50% of causes of mortality, and there are about 1/3 of unknown causes. Sepsis cause about 3%. How do we prevent this condition? We try to avoid the iatrogenic precipitant, which is we do sometimes. You have to pre-treatment with antithyroid drug in high-risk patient, and we have to correct thyroidoscosis before surgery. What are the causes or the precipitant? If you look, antithyroid discontinuation constitutes about 40% of cases, and the infection is the most common. What's the iatrogenic precipitant? Radioiodine therapy, if you give it to somebody who's high risk, or somebody withdrawal of antithyroid by physician or by himself, thyroid surgery for patient who is not prepared, or non-thyroid surgery, if you give iodinated contrast or vigorous palpation. Other ones is infection, cardiovascular, CVA, or postpartum, or DKA, pulmonary embolism, emotional trauma, or stress. So if you need to prepare somebody for surgery, this is the regimen that's mostly cited for preparation of an emergency situations. Goals after the storm to prevent the recurrence, this is most important. So we need definitive therapy, either by ablating this patient when he recover, or doing thyroidectomy while athyroid. So back to our case, patient admitted to ICU, have central line, volume status. He was given BTU 500 and then 250 over 4 hours, initiated on osmolol drip and iodine, and he was given 2 milligram dexamethasone and acetaminophen. So the summary, the thyroid storm remains life-threatening. Many cases are preventable. Early diagnosis is crucial. Aggressive approach required for survival. You need to have continuous monitoring for efficacy, and you might consider plasma exchange or urgent thyroidectomy, and we have to do a definitive therapy as a priority. Thank you very much, and I will leave some time for questions, and this is the main reason is to leave some time for questions. Thank you so much.
Thank you very much, Dr. Nasser, for your excellent presentation. It was really enjoyable. Can we delay the question?